Hello, everybody. Thank you for joining us and attending the Dermatologic Conditions in Retail Healthcare. We'll be reviewing acne and rosacea this morning. My name is Carol Patton, and I'm delighted to be with you. Next slide, please. In terms of disclosures, none of the planners or speakers have a conflict of interest to disclose as it relates to this educational activity. This activity is supported by a grant from the Bayer Dermatology, administered through their grant division for a dermatology program. Bayer has had no involvement in the planning, implementation, or evaluation of this program. Next slide, please. As with all educational programs, we have specific objectives for this session. The first is to review the skin anatomy, describe acne diagnosis, describe rosacea diagnosis, identify treatment options and management of acne, identify appropriate treatment of rosacea, identify opportunities for management of these two conditions in the retail setting. Next slide, please. As we focus on the anatomy and physiology of the skin, the first important point is to review the layers of the skin. The first layer is the epidermis, which provides barrier protection and strength to the skin. And as we know, the skin is the largest organ in the body. Its structure also contains skin appendages that form the integumentary system. And the skin, being the largest body organ, protects the body from harm, and it acts as a barrier to the body's external environment. And the epidermis is the outer layer of skin. It is composed of stratified squamous epithelial cells known as the epithelium. Like all epithelial tissues, the epithelium is avascular and has no blood supply of its own. The oxygen and nutrients diffuse into the epidermis from the rich blood supply that underlies it in the dermis, which we'll talk about in just a few minutes. Did you know the epidermis can be divided into 5 layers? The first 2 layers that we'll talk about that are the most important for our discussion today are the stratum germinativarium and the stratum corneum. And as we talk about the stratum germinativarium, it lies close to the dermis and has a very rich blood supply. And we just said that the epidermis is avascular and has no blood supply, but it gets its blood supply from this layer of the stratum. The cells in the stratum germinativarium layer are continuously dividing and subdividing, producing millions of cells every day. As these cells divide, they pick up the older cells and move them toward the surface of the epithelium. Then as the cells move away from the dermis, there are 2 very important changes that take place, and this will be real important in our discussion of the 2 diagnoses we'll be discussing today. First of all, as the cells move away from their source of nourishment and rich blood supply, they're going to begin to die. And the second important change that takes place is the process of keratinization. Keratinization is the process by which a tough protein known as keratin is deposited within those cells. Keratin actually causes a flattening or hardening of these cells as they move toward the outer surface of the skin. And keratin is also responsible for helping waterproof the skin, and that's why we don't dissolve when we get wet. We have this keratinization process. The second major layer is the stratum corneum. This is the surface layer of the epidermis. And the stratum corneum is composed of about 30 layers of dead, flattened, keratinized cells. And these dead cells are constantly sloughed off through wear and tear, and they're constantly being replaced by other cells that are moving up from those deeper layers. Now, the second layer of skin I wanted to mention to you is the dermis. The dermis actually is a very important layer of skin. It contains mast cells, inflammatory cells, blood, lymph vessels, and nerves. And the dermis is also known as the corium, C-O-R-I-U-M, the corium, and it's referred to often as the true skin. The dermis, as you see in one of the slides coming up, is located under the epidermis, and it's much thicker than the epidermis. The dermis is composed of dense, fibrous connective tissue, and it contains numerous collagenous and elastic fibers that are surrounded by a substance. It's a gel-like substance, and it is there that these fibers make the dermis strong and even make the dermis stretchable. It's very movable. The thickness of the epidermis and dermis varies depending on where the skin is located in the body. For example, skin on the palm of the hands and soles of the feet are very thick, much, much thicker than the eyelids, for example, or the inner arm. And although derived from the epidermis, the accessory structure and skin appendages are embedded within the dermis. And skin appendages would be our hair, our nails, and certain glands. Also, we find located in the dermis blood vessels, as I said earlier, nervous tissue, and even some muscle tissue is located in the dermal layer of skin. Many of the nerves have specialized ends called sensory receptors, and that's where we have pain detection, our temperature sensors, pressure. We feel pressure and sense of touch in the dermal layer of skin. Just to say a few words about the third layer of skin, the subcutaneous, this layer acts as an insulator, a cushion. We have energy and hormone metabolism occurring in the subcutaneous layer, adipose tissue and arteries. And it actually lies in the dermal layer actually lies on the subcutaneous layer. The subcutaneous layer is in some references and textbooks not even considered part of the skin. But it's important for us to realize that the subcutaneous layer, as it is often referred to, is composed of loose connective tissue and adipose or fatty tissue. In this subcutaneous layer, there are two major roles performed. First of all, it serves to insulate the body from extreme temperature change in the external environment. And second, the important function, it anchors the skin to the underlying structure. So there are a few areas of the body that have no subcutaneous layer. For example, the subcu layer of skin anchors directly to bone. For example, if you were to look at your knuckles right now, you'll see how that skin is very wrinkled and creased, and the reason that happens is because the skin over your knuckles is attached directly to the bone. There's no subcutaneous layer. So for this webinar and the diagnoses we are focusing on, I will not say much more about the skin appendages, which, as I said earlier, are the hair and nails. However, I do want to focus for a few moments on the relevance and importance of glands in the skin. If we could have the next slide, please. Here you see the layers of skin we've been talking about, this, the epidermis, the dermis, and the subcutaneous tissue. And again, you can see the highlights and the characteristics that I just shared with you about the thickness and the layers and the anatomical construction of these three layers of skin. And if you look at this slide, you will see sebaceous glands in the epidermal layer of skin. So just speaking for a few moments about the glands, there are two major exocrine glands associated with the skin. The first is the sebaceous glands, and the second are the sweat glands. Now, I'm not going to say a lot about sweat glands, but suffice it to say, for our discussion today, it's really important to focus on sebaceous glands. These are also referred to as oil glands. Sebaceous glands are associated with hair follicles, and they are found in all areas of the body where we have hair. They secrete an oily substance called sebum, S-E-B-U-M. The sebum flows into the hair follicle and then out onto the surface of the skin. There are actually a small number of sebaceous glands that open directly onto the skin surface. The sebum lubricates and helps waterproof the hair and the skin. Sebum also inhibits bacterial growth on the skin's surface. Sebum production gradually decreases as we age, and that is why we often observe dry skin and brittle hair in our aging populations. It is these sebaceous glands that can become blocked by sebum and other debris, And when sebum is exposed to air and it dries out, it becomes black, and that forms a blackhead, as we know in acne. When sebum gets infected, it is a pimple or a pustule, fluid-filled, a pus-filled vesicle. Blackheads and pimple formation are very common in adolescence because sebaceous glands activity responds to hormonal activity associated with puberty, and that's why we see heavy increases in secretion during this period. Now, as I said, I'm not going to say a lot about the sweat glands, often referred to as sudoriferous glands, but that's not really the focus of this particular webinar. If we could have the next slide, please. In the dermatologic history taking, the history of present illness, we want to find out if our patient has been taking any recent medications, any immunizations, if they've been exposed to any allergens, food, animals, plants, for example. What medications or treatments are they using, and what have the results been? Often in retail health, we will see patients who have tried many different things, and it's sometimes very difficult after they've self-treated to drill down and find the root cause of the actual healthcare issue, because they've tried so many self-treatments or over-the-counter treatments, and now they've caused a very confusing presentation. So, you know, you have to really go back to where this all began and what has been done since the onset. Use of lotions, soaps, new shampoos, or cleaning products are really important. And again, it's not uncommon at all to find patients present with chemical dermatitis as they've tried to use a variety of cleaning products, and they've really harmed their skin and denuded it in certain situations, making it very difficult to make an accurate diagnosis. As far as the past medical history, does the patient have any allergic history, atopic dermatitis, allergic rhinitis? Has there been trauma or a burn, for example? What about allergies to food or environmental factors? History of excess sweating and or skin disorders in infancy. And as we know, many patients have different sweat patterns. Some people sweat profusely, other people hardly sweat at all. So again, these are very unique to our specific patients that we're seeing in the clinic. If we could move to the next slide, please. This slide will show us some primary skin changes that occur. It's always good for the practitioner and provider in the retail healthcare setting to be thinking about the types of skin changes that occur with rosacea and acne. And the ones that would be most important on this slide would be the cyst. If you look in the slide, we see that a cyst is a palpable area. It has definite borders. It's filled with fluid, or it can be solid. And the other would be papule. A papule is a solid raised lesion. It varies in color, and it's usually less than 1 centimeter in size. The pustule, as we spoke about a few moments ago, it's a raised lesion. It's fluid-filled with pus or exudate, and it usually occurs in a hair follicle or a sweat pore. And we talked a few moments ago about why that occurs. The other primary skin change that we see is a nodule. A nodule is firm, it's raised, it's movable, and this lesion, it has indistinct borders, and usually it's less than 2 centimeters when you palpate it. The other primary skin changes are also important, but typically they are not seen with acne and rosacea. Our next slide shows an image of skin changes that you would see with the cyst. You can see the papule as it is described, pustule, and nodule. So again, these are just some graphics depicting the various primary skin changes that we would see for cyst, papule, pustule, and nodule. Those would be our primary skin changes in our diagnosis for this week. Secondary skin changes, if we look at the next slide, are usually described as crusting, where we have dried exudate or actual scabbing. Excoriation would be a scratch, removal of the epidermis, and again, it's not uncommon for patients to present with having tried to self-treat with over-the-counter medications or therapies. With scaling, we see thin flaking areas of the epidermis. We can actually see fissures, which are linear wedge-shaped cracks into the dermis, and this can be very painful for patients depending on where the lesion may occur. A scar is certainly a healed lesion of connective tissue. It's often pale in color, shiny, glistening, and some scarring is irreparable. We'll talk about that in a few moments with our diagnoses for this discussion. Desquamation is peeling of sheets of scales, and you can actually have erosion or oozing, partial loss of the epidermis. You see weeping of the skin, and that can be very painful and unsightly for the patient as well. Keloids are healed, hypertrophied connective tissue. The lichenification is thickening of the skin or deep burrows. Ulcers are deep open lesions into the dermal layer of skin, and then the striae are fine pink lines where the skin is very stretched, and that can occur from edema or other types of deformities. With respect to review of systems, we want to know if our patient has had any recent illnesses, previous history of skin disease. Have you ever had this occur before? If so, what have you done? When was the last episode, etc.? Do they have fever, fatigue, weight loss, or any viral symptoms? With regard to head, eyes, ears, nose, and throat, itching, swelling, discharge, lesions, crusting, red eyes, rhinitis, etc. In terms of the chest, have they had any wheezing, coughing, or shortness of breath or dyspnea? Musculoskeletal, what about joint pain or limited range of motion? These are very important assessments in terms of our review of systems. Our next slide, we focus on skin assessment. And again, we want to inspect and palpate the skin, noting the color and the pigmentation, noting has there been an increased or loss of pigmentation, redness, pallor, cyanosis, or yellowing of the skin. We want to assess the moisture of the skin, any dryness, sweating, or oiliness. And then, of course, to assess temperature, we always use the backs of our fingers and look for generalized warmth or coolness, noting temperature of any reddened or erythematous areas. Our next slide, we're looking at skin assessment and overview of acne. Acne is a common condition that often prompts the patient to seek medical advice. It classically starts in the pubertal years, and we talked about that earlier in our physiology and anatomy with regard to excess hormone function during these years. And when these changes occur and the patient becomes self-aware, patients can be very self-conscious during this period because of the detriment to self-image. And that usually is what causes patients to seek treatment or care. Acne is a disorder of the skin in which the sebaceous glands oversecrete sebum, as we spoke about a few moments ago. The sebum and dead keratinized cells become clogged in a follicle, a hair follicle, and they appear as blackheads or whiteheads. The clogged follicle may become infected with bacteria, producing a pimple, as we spoke about a bit ago, the pustule, the fluid-filled pustule. Acne vulgaris is the most common form of acne occurring during adolescence, but it may continue into adulthood. Acne is derived from the Greek word acme, A-C-M-E, meaning prime of life, and there are about 5,000 sebaceous glands or units on the human body, with the most of them being located on the face, the back, the chest, the upper arms, and those are the most common sites in which we will see acne. Acne lesions include comedones, papules, nodules, and cysts, as we talked about. The comedones are actually the basic lesions of acne, and they are caused by a defection in desquamation. The desquamation process is not occurring as it should normally. Now, the comedome is an interesting phenomenon. It's at the opening of the phyllosebaceous follicle, and instead of regular cellular shedding, the desquamation is reduced, and the epithelial cells that are being shed become sticky, and they form plugs that actually block the follicular opening. This is a process known as retention hyperkeratosis. It actually takes about 2 months for the accumulated shed epithelial cells, the sebum and keratin, to finally produce a comedone. So this is not a quick process. It takes about 2 months for that process to occur. Comedones are non-inflammatory lesions, and you can have an open or closed comedone. The closed comedone is a whitehead. The open comedone is a blackhead. And it gets its color from melanin, not dirt. Some people think that the black is dirt, and it is not. The black color results from oxidation of tyrosine, and the tyrosine becoming melanin. Tyrosine is an amino acid precursor of melanin, and it's a substance that is normally present in the plug material. But when it gets oxidized from contact with the air, it becomes the black color. So again, it's important in patient education. Patients will think that they are dirty or that their hygiene is not as it needs to be, and that's a misnomer. If we move to our next slide, we'll see some facts about acne in the United States. And in the United States, the cost of acne is over $3 billion every year. That is part of the cost of treatment and loss of productivity. This is an important risk factor to the health of adolescents and even some adult patients that we will see in our retail health setting, and they must be addressed when appropriate. And again, it is a very significant disease. As you can see, $3 billion is no small amount of money. While acne is not life-threatening, it has potential for physical scarring and emotional trauma. As I said earlier, the common places for acne are hair follicles on the face, the upper chest, the back, the upper arms, and there's a huge impact of acne on self-esteem and identity because these areas are very apparent, and in society we look at people, and as we know, self-esteem is really a huge issue. We're able to closely link this to adolescent growth and development. We know that it's likely to occur to some extent. It might not be significant, but again, it can be very, very significant. The goal of all to prevent disfiguring scarring. Most causes of acne can be treated safely in primary care and retail care settings, but the view as a clinician is to know there is no quick cure for acne. This is going to take time. We need to educate our patients that there needs to be steady follow-through, follow-up, adherence to the treatment plan, and to be patient as we work on a treatment plan that is tailored for our individual patients. Typically, the treatment takes 4 to 6 weeks before we will see any type of visible improvement. And that's really important because, again, we live in a society where everybody wants everything instantaneously, and they want quick action and quick resolution, and that's not going to occur. So they need to understand this before treatment therapies are begun. The response rate to acne treatment tends to be slower when compared to treatment of other infections with antibiotics, because typically we will start to see resolution of symptoms with other types of skin disorders or skin infections within 3 to 7 days, and usually total healing. So comparatively speaking, we can use that data to help our patients understand the trajectory for healing and for when they might expect visible improvement in symptoms. We must really focus on the patient and educate the family. So we do not want them to get discouraged or become non-adherent, non-compliant with the treatment plan because that is critical and essential. And again, we want to prevent secondary infections and other potential complications. If we take just a moment to look at our next slide, we will see an image of acne and the devastation it can have on the face of an adolescent. Here you see the malformations and a variety of skin lesions, as we spoke about earlier on this patient. We have a second acne image moving to our next slide. Again, you can see how disfiguring this is, how uncomfortable it would be for the patient to be interactive and engaging with others, and how this can really impact self-esteem as well as patients feeling comfortable or maybe causing them to seek care and treatment. The goal, again, for our patients is for oral antibiotic therapy. If our other treatment plans are not working, candidates for oral antibiotic treatment include patients who've had a lack of response to topical medications after we've had a trial of at least 2 to 3 months. So again, we want to make sure that we are being very thorough in our patient education, that we're taking time to explain to our patients and helping them understand the criticality of adherence to the treatment plan. Patients also who are good candidates for oral antibiotic therapy would be patients who have the ability to inability to tolerate the topical acne treatment. Sometimes patients' skin is so fragile that the therapies are harsh and can cause excessive desquamation, causing irritation, and they just cannot tolerate the harshness of the topicals. Patients who have large numbers of inflammatory lesions after several months on topical treatment are also candidates for oral therapies. Patients with severe nodulocystic acne, patients who have large numbers of inflammatory lesions located on the back or upper arms, hard to reach areas. Again, keeping in mind that if there is just too much body surface to cover with topical therapies, then we need to consider this patient as a good candidate for oral antibiotic treatment. Patients who want quick relief from inflammatory acne would also be a good candidate, but we talked about the fact that the therapy is not magical. It's going to take time. Or if we have a patient who's at increased risk of pigmentation changes or scarring. Again, these are challenges for the provider because we want to prevent particularly facial scarring and scarring in other areas of the body. And along with education, we just really want to make sure we emphasize those particular areas. The follow-up should be have a patient reevaluated in 4 to 6 weeks to monitor the response and potential adverse outcomes if there should be any, and always keeping open that the patient may need to return sooner for reassessment or recheck if any untoward signs or symptoms occur. But we should start seeing significant clinical improvement by the 3rd month of treatment. And again, if we're not seeing that, we need to consider revising our plan of care, certainly. As far as the acne pathology, what we typically see, acne vulgaris is a disorder of the sebaceous follicle. The cause is multifactorial. Both adolescents and adults can be affected, and it's most commonly seen in our adolescent population, although that's not to say we might not see it in older patient populations. Also, we've talked about the stigma, the social stigma and shame that patients encounter with acne. It is associated with a significant financial burden and considerable psychological distress. Part of the reason is that acne is just such a horrific disease, and again, we've talked at length about the physical sites where acne does occur and how devastating that can be to our patient populations. The typical patient will be an adolescent male or female who has already tried over-the-counter self-treatment, sometimes for several months, without much success. And the patient, what happens oftentimes is they'll try one therapy and they don't get a quick response like they expect they should, so they try something different. And they're really causing a lot of harm and caustic injury to the epidermis and the dermal layers of cells, and leading to an even greater potential for scarring. So the patient may present not only with numerous acne lesions, but also with dry, irritated skin, which is a common side effect of many of our topical acne medications. The females are likely to verbalize emotional distress over their appearance, and male patients are more likely to come to be seen and wait until their symptoms are quite severe. So we can expect these kinds of behaviors in our patient populations. And again, the treatment based on our acne pathophysiology is to prevent or minimize scarring and prevent permanent pigmentation change. We want to educate our patients on the essentials of acne management and the treatment plan that we've prescribed for them as an individual, and realize that mild acne is treated with topical medications, but typically our patients are going to come who need a more complex therapy treatment plan. Keep in mind, as we take care of our patients with acne vulgaris, that you need parental permission to treat certain patient populations. For example, you may need parental permission if the person is a youth younger than 18 years of age, so you want to check those limitations in your state. So moving to our next slide. If in terms of prevention, we want to wash over the areas where the acne is occurring regularly. We want to avoid heavy foundations or makeups. What will happen is patients will try to cover the lesions, and that compounds the situation, trapping the sebum, making an even bad situation worse. Have the patient, if they're using makeup, certainly for our female patients, remove the makeup before going to bed and then shower after exercise to eradicate any excess sebum or secretions. Usually using a good antibacterial soap is perfectly fine. They can use a very mild soap like Dove. They can use Dial, Lever, any of the good antibacterial soaps that you would choose or recommend. Have the patient wait at least 30 minutes after washing their face before they apply the topical acne medications in order to minimize the chance of the skin being irritated. Topical acne medications should not be used on any irritated skin or sunburned skin, abrasions. If these conditions are present, the medication should be stopped temporarily for a few days so that skin has a chance to heal and to rebuild in a normal fashion. You want to educate the patient, encourage them to avoid any contact with eyes, lips, angles of the nose, and the mucous membranes when they're applying the topical acne medications. One thing to keep in mind is that sunscreen should be used with all acne medications, especially if the patient is living in a sunny climate and during the summer. We should encourage our patient to avoid excessive handling of the face and cradling their chin on their phones or cradling their hands or cradling their chin with their hands, as we often see adolescents do in school settings and that sort of thing, because that just increases exposure and damage to the cells. And they should avoid excessive scrubbing of the face, excessive rubbing. And oftentimes, again, that's why we want to encourage the patient to wash and cleanse their skin, but not to be excessively vigorous as they do this. We will move to our next slide now. And treatment of acne in the retail setting includes over-the-counter medications, prescription creams, ointments, antibiotic therapies. If we are looking at long-term treatment, and again in retail health, because we are so accessible to our patient populations, we will see patients coming back and following up with them as necessary to have the information as the provider, as we need, for these individualized patient plans of care. Doxycycline is often considered a first-line treatment for acne. Want to be careful and caution patients regarding the chance of pregnancy or becoming pregnant. Doxycycline can be detrimental to the teeth of an unborn child and can cause permanent discoloration, so we want to be aware of that. Also encouraging the patient to give this time to work and for proper therapeutic time. As we said earlier, it can take a while for the therapies to begin to show results. Okay, moving to our next slide. We're going to move to the topic and diagnosis of rosacea. Like acne, rosacea is a common chronic skin condition. Rosacea is especially common for middle-aged adults. Sometimes it's often perceived as a cosmetic facial redness caused by alcohol, and that can be very distressing for rosacea patients because, again, they are stigmatized, there can be shame. It's a facial vascular condition, and there are several subtypes that vary in severity. But the thing is, this is very cosmetically concerning to the patient, and the first component is vascular because it usually involves a persistent redness or erythema, primarily involving the central face. And what you can see then is a development of telangiectasia, or clusters of small superficial blood vessels. And this can be very uncomfortable for patients. And people will say, what's wrong with your face, or I've noticed, and so on. And again, it's often confused with alcohol intake. The second cutaneous component involves recurrent cuneiform erythematous papules and pustules. Again, these occur around the central portion of the face, the nose, the central portion. The third component, we will see discrete changes in the connective tissue, or the hyperplasia, the overgrowth around that central face, with discrete sebaceous gland hyperplasia, rhinophyma, and this is where we see persistent yellow papules, particularly around the nose. The thing that you want to keep in mind about rosacea is that it is a lifelong condition that is typically exacerbated or made worse by sun exposure. Some of the other environmental triggers that can actually worsen or increase severity of rosacea would be hot or cold weather and wind, overheating during exercise, again, excessive alcohol ingestion, or it is associated with hot, spicy, or aged foods such as cheese, irritating cosmetics, hot baths, saunas, hot tubs, excessive caffeine, or excessive washing of the face. Now, the thing to keep in mind about rosacea is that it also is a very high incidence and prevalence in America. It affects nearly 14 million Americans, and 10% of those are diagnosed because patients come to us with symptoms of acne, the sunburn, the flushing. And it's most common in persons around the age of 60. And the persons are usually fair-skinned, persons of Irish, English, or Welsh, or Eastern European ancestry. Women are more likely to develop rosacea than men, and often patients have one or more close relatives who also has rosacea. So keeping in mind the underlying pathology and the characteristics of rosacea are not fully known, so it's a challenge. If we move to our next slide, we will talk about the treatment of rosacea. And the thing is to teach patients about avoiding triggers. Again, stress, spicy foods, alcohol, sun exposure. We just talked about a few of these areas, and also to wear a sunscreen protectant with a high protection to the UV lighting. Use skincare products that are for sensitive skin, often using non-scented products or non-toxic products will be helping our patients become even better faster. So rosacea should be treated in a timely fashion because the patient will often come with discomfort, physical symptoms like burning, stinging, soreness. And also, just as we talked about with acne, there can be facial disfigurement that is very distressing to our patients and has a major impact on their quality of life. As far as our treatment, we want to focus on tailoring a plan of care that helps meet our patients' individualized needs, and it's not a one-size-fits-all. Our education needs to help patients avoid the factors they know produce exacerbations. You can have your patient keep a skin diary and look at triggers that have caused exacerbations or flares of the rosacea. That can be very helpful. And it's very empowering to patients to also journal or write about how they felt when this occurred, because then we can really tap into how to better help them. Again, using a broad-spectrum sunscreen with UVA coverage. However, exquisite sensitivity to topical preparations may limit some of the options our patients can have. For example, zinc or titanium-based sunscreens are better tolerated and provide a better protective silicone barrier. So again, educating them, helping them see which products might be low, teaching them to read the labels could be very helpful to them. Medical management is effective only for the inflammatory papules and pustules and the erythema that surrounds them. Again, we are looking at maintenance therapy for a patient with rosacea because it is a lifetime condition. It's a lifetime, lifelong condition. If we move to our next slide, please, we will see some photos of steroid rosacea image. You can see these pustules, the central face. You can see the telangiectasia, the blood vessels, the very thin, spidery little blood vessels in the central area of the face, as we talked about a few moments ago. Moving to our next slide, we have another image of rosacea. You can see the erythema of the cheeks. You can see the pustules. You can see this central area being very affected by the rosacea characteristics. So these are very significant, and you can see the potential for self-image challenges and embarrassment. This could cause patients to stay home from work, lost dollars per day in the United States due to this severe condition. Moving to our next slide, we want to focus on managing our patients with rosacea. Again, in our retail settings, we have to be individualized in our care. It's not one size fits all, working on a case-by-case basis to enhance the care of patients who have these significant dermatologic conditions, and through improved prescribing decisions, making sure that we are trying our best to get the tailored plan of care, find out what works well for the patient, and then giving appropriate time for therapy to be maximized and bringing the patient back for rechecks if there should be any significant worsening of the condition, or scheduling the patient to come back. If patients are to be more involved in this decision-making, then we have to give them more information about their medications, their treatment plans, and therapies, and empower them to help us work toward their ultimate resolution or management. As we said with rosacea, this is a lifetime proposition, and we want to have them on a maintenance therapy. Our next slide, look at treatment of rosacea. It should be treated in a timely fashion, as the physical symptoms we talked about, the burning, the stinging, the disfigurement, this is very distressing and has a huge impact on their quality of life. Just like we've talked about acne, there are various treatment options for rosacea that are available, but most are going to have limited effectiveness. The most effective is the metronidazole gel. That's a very cost-effective, common treatment option for many of our patients. And again, having the patient keep the diary and help them to manage their symptoms is really critical for the patients. In our next slide, we're going to look at a case study. This is a patient who presented to a primary care clinician with the past few years. The patient noticed bumps and pimples on his cheeks and nose, concentrated in the mid-face, and also the flushing intensified, and he noted increasingly uncomfortable sensations of warmth and burning affecting the central face. So you can see in this case study, if you think back to the slides that we showed regarding the central facial area with the bumps, the pimples, the central flushing, the telangiectasia, very much typifies a presentation of rosacea. Our next slide, the case study continues. The patient complained that his nose had developed a rough, coarse texture, and his wife noticed that his facial flushing worsened when drinking his morning coffee. He had been doing yard work, and especially after his nightly glass of wine. This patient reported an extensive history of unprotected solar exposure associated with his work, and said that he rarely applied sunscreen. So in this case study, you can see we have multiple opportunities for patient education to help this patient better manage and prevent and avoid symptoms, along with the therapies that we may prescribe. Our next case study, the next slide will be looking at the physical exam. The physical examination of our patient revealed centrofacial macular erythema without scaling. There were fewer than 5 papules in a paranasal distribution with prominent telangiectasia, sebaceous hyperplasia, and thickening of the skin over the central face. And his nose had a boggy texture. So as we think about the possible diagnosis for this patient, it becomes very clear that this patient has rosacea. And we can see, again, multiple opportunities to work with our patient and do good, thorough, complete assessment and documentation, and then develop an individualized plan of care for this patient. There is so much good that we as providers in retail health can offer this patient in our case study, and this is a very typical presentation. Moving to our next slide. It's really important as we conclude to recognize that treatment of rosacea and acne does vary on a case-by-case basis. And it's important to follow our patients. It's not a one-stop that we will not see our patients again. We need to bring them back. We need to make ourselves available to them in our retail health settings. Again, access to care is critical, and helping our patients feel comfortable to come if they have any questions, if they're unsure or in doubt, or they have concerns about their treatment plan, very important. So this is an important consideration and a great service that is offered to our patient populations. Above all, we want to listen to each of our patients' concerns. These are diagnoses, the acne and the rosacea, that are very disfiguring to our patients. The stigma and shame that accompanies these two diagnoses is critical, and our ability to listen is really pivotal to helping expand on the patient's individual regimen and their treatment plan to get them the ultimate quintessential plan of care that they can follow and that is going to be very helpful to them on that treatment plan. So that concludes our webinar, and I thank you very much for attending.